Okay. So, namaste, good morning, good afternoon, good evening to all the members of GAPO and all the invited guests in this scientific seminar on healthy aging. Well, dear colleagues, at the outset, I would like to thank our chairman, Dr. Reddy, Dr. Anupam Sibal, Dr. Sushil Jain, and others for taking this initiative, and would like to thank Dr. Lavanya for in requesting us to have a session on geriatrics. Well, this was a wonderful idea of Dr. Lavanya, and we thought of having it, and today we are here. In Apollo hospitals, chain of hospitals throughout the country and some other neighboring countries as well, we are committed to healthcare delivery at an affordable price and at international standards. Having done so, then we thought of extending our services, and we came to preventive health checkups. Doing something reasonable in health checkups, then we thought of our senior citizens, the people who are aging, and we thought of taking the health issues of elderly people. We have started geriatric clinics at some of our centers and are including geriatrics in the academic program as well. This time, in GAPO also, which is a brainchild of the same dignitaries, we decided to have a session jointly with Dr. Lavanya, who gave this offer to us and who has invited some faculty people also, who are all welcome. I'm happy that we are doing this session. This is the first one in the series, and we would love to carry it on further. And I would like to invite Dr. Lavanya to kindly come forward, give her introduction so that we continue the program. Over to you, Dr. Lavanya Todenwade. Dr. Lavanya, please.
Thank you so much, Dr. Sarmaji. Good morning and good evening, everyone who joined us today from wherever and from the world, maybe. It is my distinct pleasure to introduce myself. I am Dr. Lavanya Kumari Tondavada, a medical professional deeply committed to healthcare, compassion, and lifelong learning. Originally, I'm from India. I migrated to a beautiful island, Trinidad and Tobago, in 2006. And since then, I have been a privilege of serving people and contributing to healthcare development across this country. With over 24 years of medical experience, including more than 14 years in dermatology and over 17 years in gerontology, my journey has been guided by a passion for improving quality of life and delivering patient-centered care. I earned my medical degree in India 2002, later pursued several advanced international qualifications, including diploma, masters in dermatology, and masters in gerontology, and also PhD in gerontology, as well as MBA in hospital and healthcare management and diploma in business administration. I have completed fellowship programs in diabetes palliative care as well, and also certification in wound care management. Currently, I'm working in a department of gerontology in St. James Medical Complex in Trinidad. I'm also the founder and president of the Geriatric Society of Trinidad and Tobago, which was established in 2023, where I continue to advocate for improved healthcare, dignity, support for older adults with my country. I can say that because I'm living in Trinidad and Tobago more than 20 years. On behalf of organizers, I extend a heartfelt welcome to all delegates who are attending today's important educational session on geriatric healthcare and healthy aging. As the global population continues to age, it becomes increasingly important for healthcare professionals and communities to work together in addressing the medical, social, emotional, legal needs for our older adults. Today's webinar brings together distinguished experts, one from Canada and one is our Trinidadian and in- interventional cardiologist, and one from India also. Expertise today is here who will share their valuable insights on healthy aging interventions and comprehensive geriatric care from multidisciplinary perspectives. We thank especially Apollo Hospitals groups for allowing this webinar to happen so that healthcare for older adults can be improved worldwide. I especially thankful to the chairman Apollo Groups and Hospitals, C. Pratap Reddy, for giving me the opportunity, and we officially collaborated since last year. As an important side note, we are pleased to announce that DocPlexus is our digital outreach partner for this webinar. And today's event is being streamed live on official YouTube channel and of Global Association of Physicians of Indian Origin. Let me introduce our chairperson, Dr. O.P. Sharma. Now it's my honor and privilege to introduce our chairperson. Dr. O.P. Sharma is a highly respected academic and healthcare leader. He is a senior consultant geriatric medicine in Indraprastha, Apollo Hospitals, New Delhi, and emeritus clinical tutor Foundation. He serves as a Secretary General of Geriatric Society of India and Professor of Geriatrics. He is also the editor in chief of the Indian Journal of Geriatric Care and Principles and Practice of Geriatric Medicine 2025. Over the years, Dr. Sharma has made a significant contributions to geriatric education and clinical practice. He has edited several important publications, academic initiatives, including Indian Recommendations for Vaccination in Older Adults 2025 and a Handbook of Geriatric Care 2019 online course, Geriatric Society of India. And he also serves as an editor cum host director of IMA. I now invite Dr. Sharma ji to deliver his remarks and conduct this scientific session. Thank you.
Thank you very much, Dr. Lavanya. This is all your initiative, and thanks for very kind words. Yes, I was introduced to geriatrics in 1982 when we formed this society, that is the Geriatric Society of India. And 99, when was declared the International Year of Older Persons, we thought of bringing out the textbook in India on geriatrics, which I conceptualized, edited, and produced. Then I produced the Indian guidelines for vaccination in older adults. And last year only, we came out with Indian guidelines for diagnosis and management of sarcopenia, a condition which we all see and treat day in, day out. Let me welcome our faculty now. First on the list is Dr. Taureef Mohammed. He is a full-time academician and a geriatrician. He is assistant professor at Shurin School of Medicine and Dentistry, Western University, London, Ontario, Canada, and community geriatrician at Durham Community Health Centre, Ontario, Canada. He has published peer-reviewed manuscripts on investigating the impact of the local healthcare system in controlling blood glucose levels and preventing complications in patients with type 2 diabetes mellitus in World Journal of Pharmaceutical Research. Great. Dr. Mohammed Actually, the treatment of diabetes is not that costly as the incremental treatment of diabetes. That means diabetes and its complications, and you thought of working how to prevent them. Dr. Mohammed has pending publication submission on using provincial administrative data to identify adults at high risk of kidney failure with care gaps who may benefit from quality improvement outreach. He has published oral abstract presentation on a thematic analysis of reflecting writing. What does it mean to be a geriatrician? Wonderful. That's wonderful. During annual scientific meeting of Canadian Geriatric Society. I think it will be a pleasure to attend your society's meeting. Dr. Mohammed conducts aging well initiatives, teaching sessions on aging well and common medical problems in older people. Over to you, Dr. Mohammed, for your presentation. Please share your slides.
Okay. Thank you, Dr. Sharma, for that introduction. And thank you to the Geriatric Society of Trinidad and to KPU and Apollo Hospitals for the invitation. It's certainly a pleasure and a privilege to be here. Good morning, good afternoon, good evening to everyone, wherever in the world you may be. The topic that I was assigned is healthy aging and interventions. And as you can imagine, this is a very broad topic, very multidisciplinary. And it can probably take up its own 2-day weekend seminar, having professionals from all different fields talk about it. But in the next 15, 20 minutes or so, I want to focus on a few things that I see as important as a geriatrician who see vulnerable older people in this society present with certain conditions that as doctors and as a healthcare system we need to address. So my objectives today, and Dr. Sharma, you alluded to this before we started the official session, but my goal today is not to lecture older people on how to eat and how much exercise to do and to control their blood pressure, blood glucose. As a geriatrician and as someone who's 37 years old, I sometimes I actually feel uncomfortable doing this in the doctor's office, lecturing people in their 80s, in their 90s about how to live. I actually, I almost feel it's inappropriate. The lecture should be the other way around. So I actually don't spend that much time lecturing older people in the office. I hear their stories and then I work with a multidisciplinary team, who each of the professionals, experts in their field, and we come together and counsel patients and learn from them as well. So today is not a lecture to older people on how to live. Instead, as a geriatrician, I think it's important for me to point out some of the barriers that, as a doctor who cares for older people, some of the barriers that I see prevent older people from actually doing all the things that we think they should do. And then I'll close by describing an integrated approach to sort of overcome those barriers and to enable older people to actually age well. In the end, the crux of the matter is really how do we empower older people in our society, in our healthcare system, in our clinical spaces. They need to be empowered. As people age, one of the problems is that they become disempowered, they become disenfranchised, and the society does that. And therefore, all the things that we lecture them about becomes increasingly difficult for them. A lot of what I would be sharing, I got from the World Health Organization. They have a learning platform which they launch as part of the Decade of Healthy Aging 2020 to 2030. And this is one way of empowerment. The platform is open to everyone. It's user-friendly. You can put in whether you're a healthcare professional, whether you're a doctor or a nurse or an older person, and you select what you want to learn and find out more, and all the information is there actually free of charge. So to start with, we don't even need a graph to realize this. We just need to go outside in this society and we see it in the malls, in the parks, when we're traveling. The aging population is increasing for the first time in recorded human history. The number of people over 65 outnumbers the number of people under 5. This has never happened before in human history. A lot of what we see today, whether it's, I don't know, wars, famine, political struggles, all these things happened before in some way or the other. This demographic shift has never happened before. It's the first time in human history. It's unprecedented, making, I think, our role very important as people who have interest in caring for older people. It's a fascinating time to actually be in geriatrics, and there is, at the moment, a lot of interest in it, spurred on, of course, by the WHO initiative, the Decade of Healthy Aging. So we're about midway through the Decade of Healthy Aging right now. Before we start to talk about healthy aging and interventions, we need to define what is aging, or more importantly, ask ourselves, what is our perception of aging and where did we get it from? Did we get it from the US TV show, the US sitcom? So this is Frank from the popular TV show Everybody Loves Raymond, you know, the old grumpy grandfather who is mostly sedentary and eats you know, donuts and bread and unhealthy meals. Is it from literature? Ernest Hemingway's The Old Man and the Sea, one of my favorite books about the old man determined really to age with dignity, regardless of all the forces of nature working against him. Was our perception shaped by our own grandparents, you know, growing up in extended households or interacting with our grandparents? One interesting thing that I've found as a geriatrician, and I'm now starting to talk to, you know, residents, medical students who are interested in geriatrics, many of them were actually influenced by their grandparents, so they were exposed to an extended family household, and their grandparents who actually influenced their interest in geriatrics. Is it our heroes? So this is Granny Lucis from Trinidad. Anybody who, and if there are any Trinidadians on the call, you would immediately recognize Granny Lucis, who won the hearts of many in the 70s, 80s, running marathons, well loved by everyone in Trinidad. So what is our perception of aging? We have to think about this before we actually get into the domain of what healthy aging is and how to achieve healthy aging. So let's look at the perception of healthy aging. This is a paper from JAMA, like more than 30 years ago, 1983. One of the opinion pieces, Aging and Caring. So I'll just take a minute to read this. So this is a physician who was invited to give a lecture to a class of graduate nurses who were studying the psychosocial aspects of aging. And basically, the lecturer spoke about a patient. The patient is a white female who appears her age. She neither speaks nor comprehends the spoken word. Sometimes she babbles incoherently for hours on end. She's disoriented about person, place, and time. She does, however, seem to recognize her own name. I have worked with her for the past 6 months, but she still does not recognize me. She shows complete disregard for her physical appearance and makes no effort whatsoever to assist in her own care. She must be fed, bathed, and clothed by others. Because she is edentulous, her food must be pureed. And because she's incontinent of both urine and stool, she must be changed and bathed often. Her shirt is generally soiled from almost incessant drooling. She does not walk. Her sleep pattern is erratic. Often she awakens in the middle of the night and her screaming awakens others. Most of the time she's very friendly and happy. However, several times a day she gets quite agitated without apparent cause. Then she screams loudly until someone comes to comfort her. After the presentation, the lecturer asked the nurses how they would feel about taking care of a patient such as the one described. And they used words such as frustrated, hopeless, depressed, annoyed. And then the lecturer said, well, he enjoyed taking care of this patient. And then he shared a picture of the patient. It was his 6-month-old daughter. And then he asked, why is it so much more difficult to care for a 90-year-old than a 6-month-old with identical symptoms? So they agree that it is physically easier, of course, to deal with a 15-pound baby compared to a 100-pound adult. The infant, they thought, represented new life, hope, and almost infinite potential. The demented senior citizen, on the other hand, represented the end of life with little potential for growth. And the point that the doctor was actually making is that until we change this perspective, it is almost impossible to empower older people to age well and to age in a healthy way. We need to change our perspective. The aged patient is just as lovable as the child. Those who are ending their lives in the helplessness of old age deserve the same care and attention as those who are beginning their lives in the helplessness of infancy. So I thought that story, I wanted to share it. I wanted to take some time to read it because I think it really captures what really is the main barrier to healthy aging for older people, and that's really ageism. And let's take an example of ageism in everyday practice. So for example, an 85-year-old man with cataracts and heart failure presents to hospital with a fall on multiple medications for his heart, and some of these medications lower the blood pressure. He had a hip fracture. The doctor sees the patient. The physician and patient incorrectly believes that falls are a normal part of aging. As a result, the physician fails to ask about the details about the falls. The patient themselves don't give the details about the falls. So the diagnosis ends up being a fall and the obvious hip fracture. They get admitted on the orthopedics, they get their hip fracture, and all of that is corrected. What about all the diagnoses that are missed and that could have been fixed? So the cataracts, easily correctable. Low blood pressure resulting in dizziness. Some of the medications could have been adjusted. Parkinsonism. I have seen many patients who have had hip fractures with a fall, get their hip fracture out of hospital, and the Parkinson disease completely missed. And to add, a fall is not a diagnosis. If someone comes in with chest pain, we want to diagnose a chest pain as an MI or a pulmonary embolism or costochondritis. But for some reason, we don't think about a fall or other geriatric presentations in the same way, whether it's a cognitive decline as well, and that's harmful. What we do instead to older people is we apply simple thinking for complex problems. And this is the recipe for disaster, really, whenever we apply simple thinking to complex problems. This is the reality of what a fall is, the tip of the iceberg, so many factors contributing to it. When I teach residents about falls, I put this picture on the side with the environment and the stairs and the gate aids. I tell them, when someone comes in with a fall, you have to get the story, you have to build a picture in your mind. And if you have an approach, it becomes actually very fascinating. You pick up things that are missed. But the ageism leads to simple thinking for these complex problems, and therefore we cause harm, and we misdiagnose people, and we miss opportunities to correct and to intervene to improve someone's functional status and quality of life. And falls is just one example, and it's one falls and mobility. It's one geriatric syndrome that we talk about. And if we consider falls only, throughout the world, it's a public health issue, a major public health issue. Falls are responsible, or falls is the second leading cause of injury-prevented deaths in the world. And in Canada, it's actually the leading cause of injury-related deaths. And as you can see, over the last few years, it's been climbing. And it's been climbing because the aging population is expanding as well. This paper from Thiam Wong and others, published in 2025, addresses this issue of ageism and falls, saying that the pervasive belief that older people just fall is not only inaccurate, but it's also harmful. And one quote that I really liked from this paper is this: to truly transform fall prevention, we must shift the narrative around aging, making it synonymous with vitality rather than decline. And I think we can expand that to all matters of healthy aging. The narrative of aging has to change to one of vitality rather than one of decline. So that is one issue, more on a personal reflective level, our perception of aging. What about our healthcare institutions and our healthcare systems? Do they help, or do they make matters worse? Do they empower older people to age in a healthy way? This is where I work in Canada, this concrete jungle of sorts. These hospitals that we've built, these multi-story buildings with elevators, sterile environment, does it really augur well for healthy aging? Or on the flip side, does it actually cause harm? There's no right answer. All healthcare systems are different. There are a lot of variations even within Canada. But just let's look at the Canadian healthcare system. One question that we always need to ask ourselves with regard to the system that we work in is what are we providing? Are we providing healthcare, or are we providing sickness care? And as proud as Canadians are about their healthcare system, it has been described as one that provides sickness care more than health care. And I just bring your attention to the bottom part of the chart. If you look at what is covered fully by the Canadian National Health Insurance, it's all medical services, hospitals, physicians, diagnostics. So somebody can go to the hospital and get 10 CT scans in 1 week, and all of the CT scans will be covered. But when it comes to home care, long-term care, when it comes to psychological counseling, when it comes to dental care, vision care, physiotherapy, all important components for older people to age well, they're actually not covered or partially covered. So as a result, older people are actually excluded from this healthcare system. And instead, because it's all based on hospitals, physicians, and diagnostics and the biomedical model, the services that it provides, or the services that are provided, are very narrow, very fragmented, and we'll see how that is a problem. Older people, to be able to age well, they don't just need medications, they don't just need lab results, they don't just need CT scans. They're all important, but what they need is empowerment, and that empowerment comes from wider society, from social services, from financial services, from healthcare services. This sort of framework for healthcare actually, an argument can be made that it actually not just excludes older people, but it actually harms them. And there are ways, there are arguments that we can use to justify that. I don't have the time to go through that, but I just wanted to bring it as an example of how healthcare systems can really exclude older people and be actually harmful towards them, and be the main barrier sometimes to them aging healthy. Instead, what the WHO really encourages is an integrated care approach, and all of this is on the WHO's website and platform for in the decade of healthy aging. And the WHO says that there is a fundamental change that has to happen in how healthcare is delivered. We need to change from this biomedical, disease-centered model to person-centered care. And in this way, we would be able to empower older people to optimize what we call their intrinsic capacity and their functional ability. And I'll describe what I mean by that in the next slide. It's a model rooted in primary care, and it's team-based and multidisciplinary. So it's not rooted in some fancy multi-story, high-tech quaternary hospital. It's rooted in your primary care in your community. This model requires us to redefine our goals and our benchmarks. So yes, HbA1c, blood pressure, cholesterol levels, all important. But again, for us to encourage and to enable healthy aging, we need to expand our goals, and we need to expand our horizons to include what we describe as intrinsic capacity and functional ability. And what intrinsic capacity is basically is someone's the sum total of someone's physical and mental energies, which they can draw upon. And functional ability is basically how they can translate that into something that's meaningful to them. This is where we have to focus, in addition to all the medical things. And we see as people age, both intrinsic capacity and functional ability, they both decrease. And our healthcare systems and our role as doctors, physicians, nurses, physiotherapists is to compensate for those losses in a dynamic and continuous way. So this is my grandfather, his intrinsic capacity. He valued writing and sitting at his desk and watching the news. So enabling him and improving his intrinsic capacity would be to make sure that he can write, to make sure that he can see the words, to make sure he can get to his desk, that he has a light, that he can see what he's writing. That brought meaning to him later in his life, that ability to just sit down and write. This is a basic framework for the ICOPE approach. It's 4 steps, very easy to follow. The basic assessment can be done in the community, in-depth assessments by doctors, primary care, and other healthcare professionals. This is a case study in integrated care. This clinic was established by one of my colleagues here at Western, George Heckman. So they develop an integrated care team based in primary care that comprises a geriatrician, primary care physician, a nurse practitioner, and I think a pharmacist. And these were the outcomes. They had better medication prescribing practices. They reduced emergency room visits by 50%, quite significant. And there was high satisfaction among patients, care partners, and even the physicians involved. They all appreciated the person-centered approach to care, the collaborative nature, and the help in navigating the system, which becomes very complicated as one gets older and has more medical problems. So in conclusion, to achieve healthy aging, older people must be empowered. Ageism is a significant barrier to healthy aging. Structural barriers do exist in our healthcare systems. Change is needed. The WHO's ICOPE approach is a blueprint for establishing integrated care. And integrated care works. It works for older people, their care partners, and even the physicians. It's a win-win-win approach to healthcare. Sorry for going a bit over time, but that's what I wanted to share. Happy to take any questions if there is time. Sorry, you're muted. You're muted, Dr. Sharma.
We have 2 questions so far in the chat.
Do you want to take questions right now, Dr. Lavanya?
Yes, only 2 questions for Dr. Taureef.
2 questions, then that's fine. I think
yes.
Be prepared. All right, please go ahead.
One question is, what is the role of cognitive health screening in routine geriatric assessment? The first question.
Yeah, so the evidence for this, it's variable in terms of, do we screen everybody for cognitive problems? I think as a geriatrician, once someone gets referred to me, it usually means that screening is necessary. In terms of primary care, I don't know if there are any primary care doctors here. I'm not too familiar with what their guidelines are. But the ICOPE approach, basically, if you look at the basic assessment, which is, let me go back to this assessment. So the basic assessment here, there are domains that fall under the basic assessment, and it basically captures the domains of intrinsic capacity. So as part of the basic assessment and the ICOPE approach, there will be a general cognitive screening test. It would not be a detailed MOCA or a detailed MMSE. That would be part of the in-depth assessment done in step 2 if they fail that basic assessment. I don't have the actual specific questions that they ask for cognition for the basic assessment. It's available in the handbook. But it's basic, some basic cognitive questions, maybe like orientation or some other sort of activity, maybe drawing a clock or something that really just does a rough screen of someone's cognitive ability, and then would, if they screen positive, they would be referred on to step 2, where they would actually do like a Montreal cognitive assessment or mini mental state exam, something more detailed. Where is this basic assessment conducted? Actually, the WHO's recommendation is really community-based. It doesn't even have to be in a healthcare clinic. It could be in sort of your community mosque or church or temple, community groups, and community workers can be trained to do these basic assessments. I don't know, does that answer the question? So there's no,
yes.
specific setting or specific tests, but it can be tailored in different settings, different opportunities as well.
The next question will be, which early interventions have the highest impact on delaying frailty in elderly population?
Mm-hmm. Yeah, so frailty, a lot of research is going into that. Really, when you think about frailty, when you think even about falls mobility, the best evidence is all non-medical. So physical activity, exercises, strength training, balance training, and healthy diet and nutrition. You have to be aware of the capitalists who are going to come and try to capitalize on the aging population and promote certain, like there are a few new places that have popped up around where I live, longevity spas and all these weird sort of interventions that seem really advanced and maybe oversell some of what they can actually achieve. It comes down to basic physical activity and diet, really, particularly with regard to frailty, and also with regard to cognition, social stimulation, social connectedness, balanced, healthy diet, regular physical activity, and all of that.
Thank you, Dr. Taureef. Dr. Sharma, would you please move on for next speaker, please?
I think Dr. Sharma is muted, right?
Dr. Sharma?
Okay. Hello, am I audible now? Our medical system is not health oriented, is disease oriented. And the same is about the reimbursement schemes. And that is the reason that aging is not being taken care of and health issues are not being taken care of. I think it is time that the people rise over it and the health professionals understand it. Very nicely, you have pointed out that there are multiple diagnoses, and as a matter of fact, a proper assessment in the triage or casualty makes all the difference. And the addition of a geriatrician in a treating team really does wonders. Thank you so much. Now it's time for me to invite Dr. Ravi Ramlal. Dr. Ravi Ramlal is a well-accomplished cardiologist with advanced training and international recognition. He has earned his MBBS and DM in internal medicine at UMI before completing fellowships in adult general and interventional cardiology, including in structural interventions at the University of Calgary and certification in cardiology from Royal College of Physicians and Surgeons of Canada. He also holds fellowships with the Royal College of Physicians, UK, and the American College of Cardiology and the Society for Cardiovascular Angioplasty and Interventions. Dr. Ramlal is actively engaged in researches and serves as a reviewer for leading journals such as European Heart Journal and British Medical Journal. He has spearheaded innovations in cardiac care, serving as co-clinical director of the Cardiac Catheterization Laboratory and head of cardiovascular EWMSC and NCRHA. In 2024, he launched Trinidad and Tobago's first heart function and cardiac rehabilitation program. Wonderful. That's great. He is currently chairman of the Clinical Governance Committee of Board of Directors at NWRHA. So I take the pleasure of inviting Dr. Ravi Ramlal to kindly give his deliberation. Over to you, Ravi. Please unmute yourself and share your slides.
All right. Good day to everyone. I'd like to thank everyone for having me the opportunity to have such a distinguished lecture and to be here with you, Dr. O.P. Sharma, and all well-recognized physicians. What I would like to do today is just to go over the healthy heart strategies for seniors and really look at the evidence-based approach from the recent guidelines that we have just published, and particularly in 2026, ASC and ACP Geriatric. Today's outline, we're just going to talk about cardiovascular aging, the overview. We do a case study, then discuss general guideline integration and applying the latest evidence, some blind spots to equity among aging population, and some outcomes and clinical governance issues that arise in terms of quality metrics in the elderly that looks really well when we have them as outcomes in hospitals, but how does that translate into the patient care? So what I'd like to start with is an 83-year-old Indo-Trinidadian retired head nurse. She has a hypertension, blood pressure 150/90, type 2 diabetes, COPD, frailty index score of 0.45, LDL 120, EGFR 50, CKD 3A, prior PCI to the circumflex, and clinically stable from a coronary artery perspective. Echo shows a LVEF that's normal with mild LVH. Her medications include aspirin, enalapril, rosuvastatin, metformin, dapagliflozin, budesonide, formoterol, and bisoprolol. when we generally see patients like this, whether we are consultations, clinical situation, we have some clear targets, whether we see them in the emergency department or whether we see them in the clinic setting, in terms of what we should do as some of our goalposts. So hopefully at the end of this discussion, we'll be able to have some clear perspectives on what are the clinical goals for a patient like this. And when I tell a lot of people in terms of what happens, in terms of when you have goals for these patients, I tell all of my fellow, basically, I let them know that we can prescribe the best medication, we can present the best data that's available. But if you are not able to connect with that patient, you're going to have some significant barriers to treatment. So as we go on, I want to focus on some key topics, and as Dr. Mohammed would have enlightened in the discussion, he basically created a great segue in terms of, a lot of the things that we talked about are disease-oriented rather than patient-oriented. And what I like to focus on, although these are disease processes that happen in patients as they get older, it's very important that we have targeted goals so that we can have positive outcomes for our patients. When we look at particular strategies related to the global burden of cardiovascular disease in older adults, it's very important to recognize that it is a high burden. We have over 18 million global deaths attributed to cardiovascular disease. It is the #1 cause of death over the age of 65. We have, according to WHO, in the next 10 to 20 years, we're going to have a double of the population in terms of the elderly. And that's because of advances in medical care and therapeutics that weren't available compared to 20, 30 years ago. And the estimated healthcare burden is going to go almost to $1 trillion per year. It is also important to recognize that 1 in 3 seniors will have cardiovascular disease, and that increases the risk of dementia. The increased risk of vascular risk increases the risk of dementia as well, which would then translate to high economic impact, rising healthcare and straining the healthcare system. So one of the main things as patients get older, we talk about blood pressure and lipid management in the older population, and how that translates into a healthy heart strategy for patients. What we'll see from landmark trials, particularly related to blood pressure, as well as patients with coronary artery disease and dyslipidemia, we'll see that what was done in a lot of the landmark trials, patients over the age of 65 or even over the age of 80 were not included in these large trials that were done in the 1980s and 1990s. So in the early 2000s, those populations were looked at, and treating hypertension in patients over the age of 80, we showed that there was a significant decrease in stroke by 30%. When you look at Prosper trial in 2002, way back when it was the 4S trial, you would see that there were data, and in the elder population, they would say, well, don't worry about the statin, there's no data on that, so we don't know what to do. But here we see that in patients with coronary artery disease, as they get older, between the age of 70 to 82, you decrease coronary events from happening. And then more recent trials, such as the SPRINT trial, showed that intensive blood pressure control was supposedly better at control arms, but we'll see that in recent guidelines, there was a little more leeway in terms of your target blood pressure in fit seniors and looking at LDL values, particularly for secondary prevention of an MI or stroke. What we have noticed is that the recent guidelines has been quite adamant that we should try to push the LDL as low as possible. There are many data that were of association with statins and associated risk of memory impairment. However, the data currently shows that the risk far outweighs, well, the benefit far outweighs the risk. It's a discussion that you need to have with the patients as well as the relatives of the patients. The most recent guidelines say that patients should be statin and ezetimibe towards an LDL goal of less than 70 for secondary prevention. But what is more important here is that although we're trying to achieve an LDL goal of less than 70, and we can use drugs like PCSK9 inhibitors or similar molecule analogs, it's very important to listen to what the patient is telling you. If they're having significant myalgia, muscle pains, you could prescribe the best statin. The patient would not have any significant benefit, because what's going to happen is that they're going to stop that medication and they're going to forget all about these goals and numbers and set points that is recommended in the guidelines. So generally, I tend to tell patients, we would like to get your cholesterol as low as possible based on how you can tolerate the medications. When we look at frailty, particularly frailty overlay and managing blood pressure by functional status, it's important to look at Rockwood et al. Data, particularly when we look at clinical frailty scores from 1 to 9. You use a quick tool assessment, and what you'll find is that those patients from the sprint frailty subgroup, intensity blood pressure monitoring, what you have is that those that had a fit score, robust, not deemed frail, you would want to target those blood pressures less than 130 on 80. But as you become more vulnerable and severely frail, we would like to have a little leeway with a higher blood pressure target for these patients, so as to reduce the risk for what was mentioned before. Sometimes we have all these definitive targets, and your guidelines, your primary care physician would say, well, these are the guidelines, this is what we need to do for these patients, these are the targets we need to do, and prescribe medications that would then lead to side effects of these patients, where they then end up with significant hypotension, postural hypotension, or fall, and again end up on the orthopedic surgeon, but no one really goes through to find out some of the reasons and rationale as to why this fall happens. So hence, in 2026, individualized target based is very important, based on the functional status and the tolerance of the patients. So really want to highlight, as patients get older, it's very important to individualize treatments, particularly for blood pressure management of these patients. When we look at medication and management of frailty, what we know, and as a lot of you all who are geriatricians would know, that a cardiac patient or a healthy heart strategy for a patient who over the age of 65 may have a prescription, particularly if they had an MI recently or the past, the drugs can be as long as 10 to 12 pills. So there's a significant high pill burden risk. And there may be medication interaction, and what someone may not be able to pick up when they have 14 to 15 prescription pills is they could lead to functional decline and significant side effect. So as you guys would know, there's a lot of data suggesting key clinical tools in which you can rationalize the medications for better outcome for these patients, looking particularly at stop criteria. And what you're hoping to achieve is to have a comprehensive medication review and the frailty assessment, clinically scoring the patient, identify medications that are giving significant side effects, and then discuss preferences and treatment goals with your patient. I think this is very important, particularly when you're looking at the healthy heart strategies, because we have a variety of different medications that may have less postural hypotension or less of a side effect of myalgia if it's a statin. And you could still achieve those targets, but just by switching the therapeutic agent, and still reduce the risk for stroke and cardiovascular outcomes. And what you end up doing is you have greater anticipated benefits, reduce adverse events, decrease hospitalization, improve cognition, and simply better quality of life. Like I tell all my patients, it's very important to have quality of life as you get older. We can do all the intervention, but if you don't have the quality of life of what is important to you, you have to rationalize, does it make sense? So getting that entire comprehensive discussion is so important to have the buy-in of the preferences your patient want and their treatment goals. When we talk about frailty and lifestyle in patients, particularly for their healthy heart strategies, many years ago, a lot of data was put out that Mediterranean diet was the best. You would decrease cardiovascular events, low salt diet, DASH diet, and that still holds true. But nutritional strategies extend beyond the Mediterranean diet, as we see in that landmark trial in the New England Journal. What happens is that you have to now think about expanding nutritional strategies for frailty. And this was one of the key things that was mentioned earlier by O.P. Sharma, is that the patients that have sarcopenia, you have to be very mindful that you have to increase the protein and have activities that will have a healthy function in muscle so as to mitigate age-related muscle loss. And sometimes it's not just about expanding the nutritional strategies. What you have to do is actually put a nutrition plan in place so that you now, just how you would have a medication with titration, there's something called a diet titration where you're trying to reduce the risk of age-related muscle loss in these patients. So very important, as these patients get older, we be mindful of limits with CKD, like in this patient that was mentioned earlier. We tailor strength exercises, and what we really want to focus on is nutrition, micronutrients, fiber, and then you want to track those biochemical markers and then involve all of your clinician in addition to the dietitian. Very important, as we mentioned before, 5 to 10 years ago, or even actually 15 years ago, SGLT2s and GLP-1s were not available for us to use. So it's very important to recognize that in healthy heart strategies, we pay attention to the right protein restrictions, the right amount of potassiums and salts. And in terms of patients that have concomitant congestive heart failure, it will be important to watch your sodium restriction and fluid management. But we went through all of that, and trying to figure out, well, yeah, so exercise is probably one of the things that we need to do for the elderly. But unless you go into physical rehab, a lot of times what I've noticed is a lot of physicians without the specialty tend not to prescribe medication. They say you just do as you could do your normal daily activities and try to reducing your risk of falling. But there's actually a way in which you can actually try to calculate a safe exercise prescription for a patient. In patients that have been deconditioned, so seniors, what you want to focus on is to have a target of 40 to 60% the heart rate reserve. And what that really is it shows you the maximum heart rate minus the heart rate at rest. And what that does, it creates that sort of dynamic cushion for activity that can be titrated accordingly with exercise. If you look, and why that is important, if you look at the prior target heart rates, most of us would have known the 220 minus the age for the maximum heart rate. But when you have the geriatric population, the elderly population, and those in the seniors, you want to look at a more accurate shift with cardiac aging. And the formula is really 208 minus 0.70 age. And what this does, it allows patients to train safely inside their actual personal physiological zones as compared to the 220 minus the age that was used previously. In patients that have beta blockade, you want to use the Borg score. And what you really want to do is to target an intensity of 11 to 13, fairly light to somewhat hard when they exit with exercise. So that gives you a good sort of guideline in terms of how you can achieve a healthy heart strategy, reaching the targeted goals of exercise in these patients. But it's also important to assess the frailty and see how much they can do. Does it get up and go? Tug testing. So all of these things you would tend to do as a pre-assessment, and then you advise these patients. In addition, one of the big things too is assessing the fall risk. I wanted to touch on heart health strategies for seniors, particularly COPD and the heart, because COPD exacerbation and heart failure go hand in hand. It increases the heart failure risk, it increases the frailty, and increases the mortality. And how that is related to heart healthy strategies really boils down in trying to avoid the risk for decompensation. And particularly, decompensations in the elderly tend to happen whenever there's a viral infection, some sort of respiratory tract infection. That tends to happen. We know around flu season, there's a higher admission rate that tends to happen with patients who have heart disease and COPD. So what you really want to focus on a heart healthy strategy for seniors is really looking at the impact of aging and what's happened with sepsis as patients get older. Because what you want to do, you see this cascade where they present to you with this atypical presentation. They present with this kind of blunted pain pathway if they're elderly and diabetic. They would not go to the hospital to seek particular attention. And in a younger heart, you have more reserve as compared to an older heart. So you will lead to significant clinical outcomes, hypoperfusion, triggering delirium, sundowning, type 2 MIs, and that whole cascade can be avoided by having your vaccination, pneumococcal vaccination, RSV, your shingles, your COVID updated vaccines, and influenza vaccine, which are very, very important. And that entire cascade will help with a very healthy heart strategies by verifying the appropriate vaccinations happen, because you would avoid all of that decompensation from a respiratory standpoint and decrease the workload on the heart. When we look at all that has been presented before, we want to look at in terms of equity. And when we talk about the heart-brain connection in these patients, many a times it's about diet and exercise. But what you really have to do in a trial, a finger trial that was done in 2015, you really just want to focus not on just the medical aspect. People underplay diet, exercise, and cognition exercises in the elderly, because by doing that, you can also interpret and actually reduce your blood pressure by having a combination of all three. So you will actively and naturally be able to reduce your blood pressures. I just wanted to highlight some common heart conditions in seniors: hypertension, coronary artery disease, HFpEF, AFib, and valvular heart disease. One of the most common valvular problem we see in the elderly is aortic stenosis. And again, just to what was mentioned earlier, when a patient have a fall, the assessment could have needs to be done from a cardiac perspective is not just a fall. A fall is not a diagnosis. This patient could have been symptomatic with severe AS. So one of the things that we're moving towards is not even opening chest or open aortic valve replacement. We now do percutaneous aortic valve replacement. Very important, although your patients are not mobile in the fullest sense, when you do an exercise prescription, you might then discover that, wait, this patient has peripheral arterial disease, and you need to do the Doppler and ABPIs. These patients are, as you get older, there's inherent risk for atrial fibrillation, and a careful discussion about anticoagulation and fall risk needs to happen so that there's a tailored therapy for those patients who are elderly. HFpEF and HFrEF is very important that we didn't have these medications many years ago. SGLT2, your ANIs, which have symptomatic relief in these patients. But more importantly, the patients that tend to have side effects from these medications tend to be the elderly. So you have to be mindful of the UTIs, catching it early, so as to really reduce the poor outcomes in these patients who are prescribed this medication, and really have a multidisciplinary team. Again, in these patients, frailty screening is very important. You assess the speed, the gait, cognitive thinking, nutritional status, and it's always a team-based approach. From a heart healthy perspective, the elderly population, as a clinician, you're going to get somebody that may have a diagnosis of cancer. And it's very important to do something called LV strain, because you can protect that patient's heart to live on and to protect the LV function and give a good quality of life if you detect it early, so that you could put LV remodeling therapy quite early on. So cardio-oncology is very important, and what you really want to do is do something called global longitudinal strain for these patients. When we look at all that we discuss, we can see that sometimes there is a disparity in care in patients, particularly if they cannot afford their medication. They will skip medications due to cost. And then secondly, those who live in the city versus rural, there's a huge disparity in not only medication, but in terms of how vaccination happens as well. So what we should do is encourage community health works where we could have home visits, increase medication adherence, and decrease hospital admission. In the advent of telehealth, sometimes you don't need all the fancy iPad, a simple phone that you could call someone and get the information of, did you take your medication? Did you check your blood pressure and your heart rate? And did you exercise today as prescribed? Will go a long way. There are now wearable AFib detection devices, but also at that age group, there's some barriers to digital literacy. So by overcoming, one way of overcoming this is really by having a significant clinical counseling. And what you want to focus on is...
If you could sum up, Dr. Ravi, you are exceeding the time, sir.
Oh, okay. Right. So I think I'm on the last slide here.
Okay.
Yeah. So what you really want to do is focus on encouraging the patient, counseling the patient to have a fair goal towards a multidisciplinary teamwork, which means you're going to have a really good outcome. So that these goals will make a huge difference where you have better outcomes for your patients. All right? So
Dr. Ravi, sorry to interrupt. Please on your camera, please. People asking before you end this session, please.
For some reason, it's not.
Oh, okay.
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 Please carry on.
Carry on.
Could you see me?
No, not
Carry
yet.
on, please. Carry on, please.
Okay. So what you really want to focus on healthy heart strategies for seniors, as in this case that we discussed. In your patient profile, you want to target your blood pressure based on the patient's frailty, the LDL less than 70, your HbA1c close to 7.5, and a frailty index of less than 0.25. So in general, what you really want to do for healthy heart strategies for your patients, you need to have, yes, the evidence-based data, but you need to have a holistic team-based approach to achieve these goals. And one of the main things you should be mindful of is that if your patient or their caregiver isn't involved in the discussion, having those clinical goals makes no sense, because the adherence state is going to be a significant barrier. So very, very important to engage your patient as well as the caregiver, so that you can give all of what we discussed earlier, a healthy heart strategy that's best for that patient. All right.
Thank you so much. Thank you, Dr. Ravi, for a wonderful deliberation on healthy heart. And I'm so happy that remembering it all the times that you are dealing in a geriatric symposia, you have taken care of frailty, sarcopenia, disability, which follow one after another. You have taken care of nutrition, you have taken care of the electrolytes, you have taken care of the polypharmacy, the pill burden, support system, etc., etc. Thank you so much. Madam, are there any questions, Dr. Lavanya? Dr. Lavanya?
Yeah, yes, we had some questions to
Please
Dr.
go
Ravi
ahead.
Ramlal. Somebody asked about how do you balance aggressive cardiovascular prevention with the risk of polypharmacy as per your experience. Share practical lifestyle interventions that actually show adherence in older adults. That is a question.
Dr. Ravi, unmute yourself and reply, please.
Sure. So what we can see is that, so to answer the first question, Dr. Lavanya, is we look at the first bit in terms of what are the practical aspects in primary prevention for these patients. What you'll find is that in my practice, I would start a few patients on single pill therapy to see how they will tolerate a particular medication. So if we look at something simple as the hypertension guidelines, where the recommendation, first of all, is a combination pill therapy, I wouldn't start that patient directly in this particular age group on double combination therapy. I'll do single, see what the patients can tolerate, and then switch over towards a combination pill. What I've also gained is that there are some antihypertensive medication that has statin therapy as well. So you can prescribe one pill that will aim towards reaching the targets for hypertension and dyslipidemia for these patients. So you're more able to capture compliance, adherence, and ease of taking once you have identified that they can tolerate each one of these medications independently.
Thank you, Dr. Ravi. I think compliance is a big issue always. So I think you very nicely covered. Dr. Lavanya, are there any more questions, or shall we go?
One more question, final
Yeah, please
question
go
to Dr. Ravi. What your thoughts on AI in geriatric? That is a little complicated. If you want, you can let us know after next session, please.
Okay. I think, thank you so much. Thank you, Ravi, for a comprehensive coverage and always taking care that you are not only a cardiologist, you are also a geriatrician and a human being. Now, the next speaker, the last batsman, is none other than Jayantha Sharma, Dr. Jayantha Sharma is an expert in internal medicine, has great interest in geriatrics and critical care. He's professor and senior consultant at Apollo Multispecialty Hospital at Kolkata, with 20 years of experience in the field of medicine, geriatrics, and clinical cardiology. He is a fellow of Royal College of Physicians, fellow of American College of Physicians, fellow of Indian College of Physicians, fellow of Indian Academy of Clinical Medicine, Cardiology Society, and also of prestigious Geriatric Society of India, whose currently he is a vice president as well. He is distinguished clinical teacher, faculty, and academician and has various publications in national and international journals. He has contributed chapters in many textbooks, including my textbook of Principles and Practice of Geriatric Medicine. And he has been a speaker, invited speaker at API, CSI, GSI, IACM, IPF, IMA, etc. Over to you, Jayant, for your deliberation. Dr. Jayantha Sharma.
Thank you, sir. Thank you. It's nice to meet all of you in this good evening. So my sir, my mentor, my teacher, Professor Ravi Sharma sir, and all the distinguished and my esteemed colleagues. I'm fortunate enough to speak on this platform, and I'm really thankful to Professor Ravi Sharma sir to give me this opportunity on behalf of the GSI to speak on this international platform, and hope I'll do some good thing for next 10-15 minutes for all of you. So with this, I'm starting my topic, which has been assigned to me today. Sir, I am audible properly?
Yes.
Yeah. Okay. Thank you.
Well, kindly share your slides and start
Yes.
your.
Yes, sir. Yeah.
Please.
Yes. Yeah. Okay. So the topic which has been provided to me to speak on this forum today is the Comprehensive Geriatric Assessment, that is CJA, the medical, social, and legal perspective. So it is a huge topic. I would like to make it short for a brief understanding all the issues, because the medical, social, and legal perspective is a huge subject. So with this, I'm starting my talk. What are the basic issues in geriatric care as a whole? Because my sir is there, son is pioneer of this branch, Geriatric Society of India. He is the founder member. So the issues in geriatric care, what we are facing in our daily clinical practice, that is a multidimensional challenges require multidisciplinary solutions. The first one is the health-related challenges in the form of high burden of non-communicable diseases and multimorbidity, geriatric syndromes in the form of frailty, sarcopenia, anorexia, polypharmacy, and medication-related problems, poor mental health. The second issue is the system and service gaps, insufficient geriatric-friendly infrastructure, shortage of geriatric workers, limited access to the comprehensive geriatric care, especially in the rural areas. Third one is the social and environmental challenges, the social isolation, loneliness, lack of community support, breakdown of family nowadays. Seen we are detached, all people are from joint family to become nowadays a nuclear family. The policy and program gaps, low awareness about the healthy aging, under representation of older adults in research and clinical trials, and the last and the foremost, the technology and information barriers, limited access to the telehealth and mental health solution, data privacy, digital divide, and low digital literacy. So with this, I would like to way forward how the CGA and Geriatric Society of India and Geriatric Society of all over the world, the global caregivers, how they can way forward. The person-centered and age-responsive care, strengthen the primary care and community support, build geriatric workforce and training, promote research and innovation in aging, leverage technology in inclusion, not exclusion, and foster multi-sectoral collaboration and age-friendly society is the key message at this first slide I would like to say all of you. So epidemiology of aging, if you see the global phenomena, it is a national priority. In India, what I can say, more than 138 million older people are at present in 2026, it is around 10.1%. The projected to reach, it is around 22.5% population by 2051. The global trend is also showing the same thing. The demographic transition in India in 1981, only 5.5% of the older population was there as the age of 60 plus. In 2021, it is 10.1, 2031, it is projected 14.9, and 2051, it is projected more than 22.5%. Why the aging is increasing in society? Because there is a declining fertility rate, increasing life expectancy, advances in healthcare and disease control. And as a whole, what happens for that? The key impact of population of aging is high burden of non-communicable diseases, multiple comorbidity and complex care, rise in frailty, sarcopenia and geriatric syndromes, cognitive decline and mental health challenges, greater demand on health systems and long-term care. So the vision for the future should be healthy living, functional ability, participation, security, and dignity and autonomy of the elderly population. The geriatric syndrome cascade, if you see this diagram, as the age advances, there is a high chance of fall, there is a high chance of frailty and immobility, there is a weight loss, exhaustion, slowness, increased incidence of incontinence, delirium and dementia, and this whole cascade is going on one by one. So the geriatric syndrome rarely exists in isolation. They form highly interconnected self-amplifying feedback loops across the multiple organ systems. So if I can unpacking the geriatric syndromes beyond the traditional diagnosis, the geriatric giants are, first one is a delirium, second is a dementia and cognitive impairment, third one is the fall, and fourth one is the sensory impairment. And all those are interconnected with each other. The core concept is that these syndromes do not fit neat metabolic or geriatric genetic categories. They require the interdisciplinary blueprint for comprehensive geriatric assessment. The frailty, the primary target of assessment. The frailty is a biological decline across interrelated organ system resulting in a catastrophic loss of reserve. It is an independent predictor of surgical complication, disability, and mortality. As the age advances, time advances, the frailty increases. The shifting the paradigm, what is CGA? That is comprehensive geriatric assessment. The first one is a functional capacity in the form of gait, balance, active life, social and environmental context, mental health, and medical review in the form of diagnosis, polypharmacy, nutrition. So the key takeaway is that CGA reduces hospital readmission, delay the permanent relocation to care facility, and lowers mortality by shifting from disease-centered to person-centered care. So the CGA is a multidisciplinary diagnostic process that evaluates medical, functional, and social aspects. So in older adults, the frailty screening, a lot of screening systems are at this moment we are having. And if you can say, each and every score system is having some different score. It starts from 0 to 5, 0 to 7, 0 to 10. My dear colleagues, the blueprint for the comprehensive geriatric assessment, that is CGA, the CGA is a multidisciplinary diagnostic process designed to maximize overall health by systematically quantifying a patient's physical, psychological, social reserves. First one is the medical, if the patient is having any comorbidity. Second one is the functional. Third one is the cognitive. Fourth one is the affective. Fifth, the nutritional. Sixth one is the social support. The seventh, the polypharmacy. And eighth one is the environmental and safety process. So transforms fragmented symptom chasing into a coordinated person-centered care plan that is called in general the CGA's comprehensive geriatric assessment. So this is the ecosystem dashboard. What are the functional domain? Measuring the independence. The lower ADL scores consistently predict hospitalization, institutionalization, and mortality. So early IADL decline often precedes rapid functional deterioration. So different scales are there. Second one is the cognitive domain, tracking the neurological reserves with dementia prevalence reaching up to 40% in adults over the age of 80. Baseline cognitive testing is vital to distinguish chronic decline from acute and reversible delirium. The tool comparison metrics are Minicog, MOCA, and MMSE tools are there. The effective domain is unmasking the hidden depression. Untreated depression amplifies disability and triples the likelihood of non-compliance with cardiovascular and chronic therapies. As my previous speaker was talking about the cardiovascular system, so the unmasking hidden depression aggravates the cardiovascular complications also. So the geriatric depression scale, it is again 1 to 5 scales are there. The bypasses the somatic symptoms like fatigue or weight loss, which could just be the aging to focus purely on mood. The frailty and falls domain, quantifying the physical vulnerability of the geriatric patients. Frailty is an independent predictor of major morbidity and mortality distinct from the chronological age. The global rating system is the clinical frailty scale, that is CFS. The rapid 9-point visual scale feasible at the bedside reliably predict the mortality, length of stay, and institutionalization. So diagnostic triad are there for this CFS. Now come to the clinical pathway, how we can screening and triggering the assessment. There is a 4 steps are there. The step 1 is a broad population. Rapid screening by clinical frailty scale. Second one is the risk identification if the patients fail or pre-fail or schedule for a burdensome treatment. Step 3 is the full comprehensive geriatric assessment, interdisciplinary evaluation by the lot colleagues. And the step 4 is the go ahead with the action, tailored multidimensional intervention. So the key insight is the full comprehensive geriatric assessment is a resource intensive strategy screening ensures specialized resources are directed to patients with the highest potential for reversible decline. But the implementation friction, the barriers to universal CGA, it is a bottleneck phenomena or bottleneck diagram. The time-intensive nature, multidisciplinary resource drain, the no-do gap. If we can see all the 3 aspects, comprehensive multi-domain assessment requires significantly more than time than the standard 15 minutes primary care episodic visits. Number 1, true CGA requires coordinated team, physicians, specialized nurse, physiotherapy, social workers, which may facilitate the lack. The no-to-do gap, a severe shortage of trained geriatricians in society and a lack of standardized reimbursable protocols for existing or executing the CGA in high volume wards, it causes a bottleneck phenomena and causes the bottleneck diagram. So we are having some operational drawback. So the operational bottleneck resulting in limited CGA implementation and missed opportunity for patient care optimization. So this is the point what we are looking forward and we are taking care of, and we are working on this, how to minimize this or how to avoid this bottleneck phenomena. So the unmet needs matrix, the physical vulnerability, the up to 48% of older adults face at least one unfulfilled healthcare need, drastically accelerating functional decline and hospitalization risks. What are the 4 quadrants of that? Quadrant 1 is the medical gaps, polypharmacy and chronic disease complication. Quadrant 2, the functional limitation in the form of undiagnosed decay in activity of daily living, that is ADL. The quadrant 4, the psychological challenge, undiagnosed and untreated depression and anxiety. And the 4th one is the social needs, social isolation, financial insecurity, and severe caregiver strain. So these are the 4 quadrant, the unmet needs matrix we are noticing in our clinical practice whenever we are dealing the geriatric population. So the CGA in action, the transforming acute hospital outcomes. Nowadays, a lot of super specialties coming in this field, that is orthogeriatrics, ortho-oncology, ortho and geriatric emergency and surgery. So these are the subjects are coming in near future. Geriatric psychiatry is also doing a very good potential for the geriatric patients and for this comprehensive geriatric assessment in action. So adapting the blueprint for the community and nursing homes, what the community should do and what the nursing home or big hospital should do. So the community at this level, the focus is our prevention, the targeting community dwelling adults, so that our target is if the patient is a frail, the patient is having a geriatric population, rather than stay in isolation, they should stay in a good community. So community dwelling is having a good chance of better outcome in comparison to the patient is staying alone. And the second one is the nursing home care maintenance. So the continuum of care, multi-component intervention, exercise, nutritional supplement, de-prescribing, home hazards, sustain physical independence, and reverse physical frailty for up to a year. And if the patient is unable to maintain that one, go to the nearby hospital for the maintenance focusing, targeting high vulnerable populations. The assessment multi-lead targeted intervention, that is exercise, nutrition, de-prescribing, and supplementation. So from the geriatric point of view, if a patient becomes gradually frail and unable to do his daily activities, one-time consultation usually fail. Hospitalized frail older patients only benefit from the CGA when accompanied by continuous optimized management from all aspects. So the regular exercise, heat resistance, and aerobic training to increase the muscle mass, decrease falls, and improve functional performance. Second was a good nutrition, calorie and protein supplementation. De-prescribing reduces the polypharmacy to lower the medication side effect, and supplementation in the form of vitamin D administration, calcium supplementation, or other forms of vitamin supplementation reduces the hip fractures and mortality. So overcoming barriers, the path forward for us from the geriatric point of view, here is care portability. Number one, expanding the CGA beyond hospital walls into home-based and technology-supported community models to ensure longitudinal follow-up. Second one is the educational integration, embedding the core geriatric competency, functional assessment training, and frailty awareness into all standard medical, surgical, and nursing curriculum. So if we can advocate in our geriatric CGA curriculum from the MBBS level, for the nursing level, for the paramedicals level, we can have a very huge outcome. And the last question in this previous speaker, it has been asked, the AI, artificial intelligence and geriatrics. So digital health and automation, it is a huge chapter. Last week, I was talking on the geriatrics and artificial intelligence because the whole medical science is now giving more focus on the AI, artificial intelligence, and what the geriatrician or geriatric physicians should do with this artificial intelligence and how they should cope up and they should adjust and adapt it. That was my last topic when I was speaking in last week. So the digital health and automation, implementation of the electronic frailty index, utilizing routine primary care electronic health records to automatic population level screening without added clinical burden. AI is a very booming subject and it will help the geriatric population if we can utilize it properly, and we can telemonitoring our geriatric patients from our own home or from our own hospital clinic or from the hospital level. So the blueprint, optimizing the aging trajectory. First one is the identify the unmet needs across medical, functional, psychological, and social domains. What should we do? The measure. Frailty is a quantifiable risk state, not an inevitability of age. And the third one is the act. Do. Assessment is only the first step. Interdisciplinary, nurse coordinated intervention, exercise, nutrition, de-prescribing are the cure. So the final takeaway, by implementing comprehensive geriatric assessment, health system transition from reacting to disease to proactively preserving the function, dignity, and quality of life for the aging population. That is the message the CGA is always giving to all of us. Now come to the balancing act, the social, medical, and now the legal aspects. what the CGA and geriatric population, the legal aspect we should know and we should take care of. The navigating the ethical and legal frontiers in geriatric care. This is a very balancing act. The dual pillars of clinical ethics, because nowadays, due to the evolution and advancement of the medical science, artificial intelligence, we are having a lot of polypharmacy and multimorbidity because of the lot of super specialists we are having in our field. Over 65% of individuals ages more than 65% experience 2 or more chronic conditions, and more than 50% of these older adults take 5 or more medications concurrently. This is a regular phenomena in our clinical practice. Whenever we are seeing a prescription, we are seeing one elderly patient, more than 5 prescriptions or polypharmacy is going on each and every prescriptions. So the beneficence of bona fide intent, the obligation to act in the patient's best interest, and non-maleficence, that is do not harm, the mandate to avoid intervention that causes unnecessary injury. So this is the thing. One aspect, we should give them the benefit, and the second aspect, we should not do any harm by prescribing multiple medication. That should be a pillar, or you can say the dual pillars of clinical ethics. So each and every clinician should take care of it. The paradigm pivot in care goals, one is curative care, another is the palliative care. What is the curative care? Primary goal is the longevity, and palliative care is the quality of life. The interventional focuses are aggressive medical management, another is the pain and comfort management. Metrics of success is disease eradication, and the third one is the symptom relief. The aggressive treatment that extend life may not necessarily improve the quality of life for the older adults with multiple chronic conditions. So the recognizing is important from the core ethical duty from a primary care physician or geriatrician. Medico-legal aspects of geriatric care. So that was the legal aspects. First and foremost, whatever may be the age for the geriatric population, his age may be 65, 68, 70, 80, 90, whatever. The patient dignity and right is the foremost or foremost important for all of us. So for that reason, we should have a decision-making capacity, medication management, advanced care planning, and elder abuse and neglect. The elder abuse and neglect, the uphold the strict legal and ethical mandate to identify and report suspected physical, emotional, financial, or sexual mistreatment to the elderly population or older adults. So the key action should be there from all aspects, mandatory reporting protocols. So the multidisciplinary approach is needed from the medico-legal aspects for the geriatric care, seamless collaboration between healthcare, legal, and social services to construct an impenetrable shield around the rights and well-being of older adults, because ultimately it is my patient and our patient and my patient, our patient dignity and right is the foremost and foremost importance for all of us, all over the world. So the multidisciplinary ecosystem, the patient's best interest should be my primary focus. Ethics committee should be there, resolving high tension moral disputes. Physician should be there to diagnose and prescribing intervention. Nurses should be there to give the best services. Legal advisors should be there to ensuring alignment with regulatory frameworks, and social support and family support providing psychosocial grounding. No single ethical dilemma is solved in isolation. Alone, I cannot solve all the problems. So, safe ethical geriatric care demands continuous communication and centralized system across all these nodes, all over the states, all over the countries, all over the global ecosystem. So, for the patient's best interest. The legal and regulatory protective framework, meticulous documentation, the most important aspect, and second one is the role of legal counsel. And both of them can do this. Healthcare providers must strictly adhere to the advanced directives. Any deviation from the documented desires of the patient can lead to legal penalties. They should take care of that and they should mind about it. Resolving bedside decision, making the conflicts, because In our clinical practice, whenever we are entering into the ICU as a senior physician, what we are noticing, there are triad. One is patient wishes, what the patient himself wants. I had a patient whose family wanted to pursue aggressive treatment, but the patient had expressed a desire for palliative care only because he was around 84 years old. Navigating these conflicting wishes required careful communication and a thorough understanding of both ethical implication and legal requirements. Patient doesn't want to take aggressive treatment, but the keen demands aggressive life-sustaining treatment. Patient is on ventilator, patient is on renal supplement therapy, patient is on 3 or 4 inotropic support, but patient doesn't want any further treatment. The clinical reality from the medical futility, psychological limits of a multimorbid patients. So this is clinical decision should be taken very carefully with a comprehensive way or comprehensive environment. So another 2-3 slides. The navigating the gray area of patient autonomy, that is necessary safety intervention and absolute patient autonomy. So we have to titrate between these two parts, what the patient wants, what the family wants, and what the patient's inborn capacity to fight about all these multimorbid condition inside the ICU or in the last stages of life. Advanced instruction as the anchor during decline, patient process capacity to consent, advanced directives act as the anchor. From procedural barriers to clinical empowerment. In India, the Supreme Court in last 2023, that is 2023, that Supreme Court of India amendments unlock the practical use of advanced medical treatment by replacing the judicial bottlenecks with a localized medical board-driven frameworks. Pre-2023 framework, there was required judicial magistrate sign-off, but in 2023 paradigm, the streamlined the two-tier medical board system. Easy accessibility and execution, rapid clinical-led execution with strict 48 hours SLAs. It has been paradigm in 2023 after the Supreme Court intervention for the geriatric population. The 12-step pathway for advanced medical directives in India. Phase 1 was the creation, phase 2 is the review, and the phase 3 is the execution. So these are the latest 2023 guideline which has been given to us. The execution engine, the navigating the medical boards, when a terminal patient lose capacity, the 2023 guideline mandate a rapid two-tier clinical review to validate and execute the AMD. So we should always read about these basic things for our clinical practice and what should we do and what we should not do for our geriatric patients from the legal point of legal aspects of view. So honoring the Sadharma through palliative care. In Indian philosophy, or you can say the Indian doctor, what we are doing, the honoring the Sadharma through the palliative care. The implementation of advanced medical directive is fundamentally a transition of care. Life-sustaining treatments are ethically withdrawn in accordance with the patient's binding refusal. The clinical focus expands to prioritize profound comfort, dignity, and family support. So one aspect, life-sustaining intervention, another aspect, comprehensive palliative care, and we should balance in between both the things, right side and left side, both. So my dear colleagues, my respected teachers, my seniors, my take-home message in today's session is the population aging is rapidly transforming India's healthcare landscape, demanding stronger geriatric focused system, policy and trained workforce. The frailty, multimorbidity, cognitive decline, immobility and social isolation are emerging as major geriatric challenges beyond traditional disease models. It is more in the urban population rather than the rural population what we are noticing. Comprehensive geriatric assessment is central to holistic elderly care by integrating medical, functional, psychological, and social evaluation. Healthy aging requires multidisciplinary, person-centered, and community-based care rather than the individual care with emphasis on dignity, autonomy, rehabilitation, and long-term support for our elderly patients. The future of geriatric medicine lies in inclusive healthcare, research, digital adaptation, and public health innovation to ensure healthier and more independent aging. And the last and most important is artificial intelligence is a part and parcel of the geriatric care, and it will be a boom in next 10 to 15 years. If we are not adopt the artificial intelligence in geriatric care, we will be lag behind with the time, and we should be think about for our geriatric population and include the artificial intelligence in our day-to-day care, patient-centric care. Thank you, all my respected colleagues.
Thank you so much, Dr. Jayantha Sharma, for a masterly lecture in which you have highlighted certain two things which are not being talked about routinely. Yes, over last 2 decades or so, we have become vigilant about early mobilization, physical exercise, nutrition. But the two things which you spoke today, one is de-prescribing. It really requires a big heart, a courage to do the de-prescribing, and which I think only a geriatrician can do. And secondly, about the preservation of function of the organ, that is something very, very important that you have highlighted. Thank you so much. Dr. Lavanya, are there any questions? You can take them, please.
Yes, yes, please. Thank you very much to all the guest speakers, Dr. Mohammed, Dr. Ramlal, and Professor Sharma. But I would like to ask one question to Dr. Taureef. Could you please give like suggestions to Trinidad and Tobago, what best, concerning about the aged homes, and a lot of people miss the appointments due to lack of transportation, and all these things happen. Please do little suggestions to me. Why means most of them, as Dr. Sharma mentioned, adaptation, and these days isolation, and a lot of things happening after COVID also, and people is in a very busy lifestyle, and they want to keep their parents in a sometimes if they have like a full economic conditions, like they want to keep them like a sophisticated aged homes like that. But during the adaptation, a lot of them, they don't want to express their feelings, but they keep quiet, and at the same time, within a 6 months to 1 year period, deteriorating health conditions. Mentally, I can say that. I'm seeing a lot of them when they're moving from home to aged homes. What is your suggestion in that?
Yeah, I think it's really a universal problem, and everything that you just said, I think we experience it in Canada as well. I remember a year ago, I had a centenarian, a 100-year-old woman who came with her son to clinic for osteoporosis and frailty, and they had to hire private transport, and she had to pay, I think, over 100 Canadian dollars to come to clinic, and she's 100 years old, because she had to get special wheelchair accessible transport. The aged homes, institutionalization of the elderly has become the norm in Canada. So I'm talking about Canada because this is where I've been working for the last 7 years. So my experience in Trinidad is a bit limited, other than like my own experience with my grandparents who are now past, but who were all aging quite significantly over the last 5 years or so. So in Canada, institutionalization of the elderly has become a norm, and it's become a source of what I see as really society inflicting harm on the elderly because of how normalized institutionalization has become. One journalists here, Andre Picard, described nursing homes in Canada as warehouses, where Canada houses, shelves their elderly. And we saw in the COVID pandemic, Canada had the highest rate of COVID-related deaths among institutionalized patients in the developed, among the developed countries. So I don't know if I'm in a position to give advice to Trinidad. I feel like we need advice on how to treat elderly people in Canada. But with regard to age homes, even when I'm talking about aging among like family, among friends, in community circles, the first thing that comes to people's minds is age homes and long-term care homes and nursing homes. And I think we have to remember when we're talking about long-term care, institutionalization in particular, because long-term care can happen in your village and in home if proper home care is available. When we think about nursing homes, the first thing we have to admit and recognize that it's not a solution, it's an outcome. And it's a poor outcome in the same way that a hip fracture is an outcome, in the same way that, say, a fall is an outcome. Admission into an old age home is an outcome. I'm not saying there is no role for it. There is a role for it. But if we consider it as a solution, we would turn into the Canadian model, where it becomes the norm. And a lot of money is invested in it, a lot of resources in it is invested in it, and then home care suffers as a result. And therefore we have these large volumes of people going into institutionalization, going into institutions. Their mortality risk automatically increases exponentially once they get admitted, and then, as you described, they become very isolated, very sad, very disconnected. It's very sad. It's like you're herding all these old people in a warehouse. It's not really a way. It's not, to me, and also this is probably because I grew up in Trinidad. It's not really the way we should treat our elderly. I'm not saying there's not a role for it. There is a role for it, but we should see it as an outcome. And we should recognize that while we think about institutions and nursing homes, we need to give even equal attention to home care and supporting caregivers, family caregivers, unpaid caregivers, and this is where this is beyond healthcare. This, your Ministry of Social Affairs, Social Development, your Ministry of Finance, seeing how these vital services can be financed and can be resourced so that our default is not nursing homes. Otherwise, we turn into the UK and Canada, where nursing homes become really a business, and they basically milk patients at the end of their life for all of their money. And basically, there was a recent article in the UK Guardian about how these old age nursing homes operate in the UK. And basically, their residents are like human ATMs, where it's just a continuous dispensation of money just for shelter and just for safety. So I think first, before we default to nursing homes, we first need to recognize it and put it in the correct framework. With regard to the transportation question, yes, and that's where this has to be multiple sectors involved. The WHO has this document on how to establish age-friendly cities and communities. It's available on the platform for the Decade of Healthy Aging platform. And these issues, they talk about how to develop age-friendly transport systems for your older, vulnerable people. One example that comes to mind is these ride-sharing services and apps that are very common. Now they're actually senior-friendly profiles, so that you call an Uber and you have a senior version, so that the Uber driver knows that, you know, you may need help with your groceries, or you may take a bit longer to come outside. And I've noticed that more caregivers that I see in clinic, they are actually using these apps and calling the Uber for their father, mother, while they are 2 hours away in Toronto. They're calling an Uber for their mother to come to clinic in London. So that's one possibility. But of course, each society, and that's another thing with geriatrics, it's so culturally based, so societal based, that something in Canada may not necessarily work in Trinidad and vice versa.
Thank you very much, Dr. Mohammed. Yeah, any other question, Dr. Lavanya?
Yes, one more question to Dr. Ravi Ramlal. As per your experience, somebody asked this question: practical lifestyle interventions that actually show adherence in older adults. And again, AI system, because why I'm asking, these days I'm seeing like in news articles, robotic surgeries, cardiac. What you think about all this?
Dr. Ravi, if you could unmute yourself, please. Dr. Ravi, kindly unmute yourself. Dr. Ravi Ramlal, kindly unmute yourself. I think either
I'm not sure. Okay.
he's disconnected, or and now any other question? Yeah, Dr.
Can you
Ravi.
guys hear me?
Ravi, could you reply Dr. Lavanya's question, please?
Dr. Lavinia, could you repeat that?
As per your experience, you can share practical lifestyle interventions that actually show adherence in older adults, that one. And again, AI system, how it going to be impact in especially the cardiology. And also these days I'm heard about robotic surgeries, cardiac. Could you please explain briefly?
Okay, so the first one that deals, so those are 3 questions we have there, right?
Yeah.
So the first one that deals with adherence, is that the question?
Yes.
Okay, so practical life. So one of the big things that we do, I think, what happens in our cardiology clinics, I'm not too sure how it is in different parts of India, but our clinics sometimes could have 100 patients, 100 in the public sector, that is, and it's an all-day clinic. As a specialist, it's a challenge to advise 100 patients on how to take medications. What we have done is we've actually attached social service supports to now do the counseling parts with a psychologist that is enabling the patients to find where the barriers exist with regards to their adherence. In that being, is it a cost issue? Is it a literacy issue? Is it an issue that's related to being not having any social support for taking these medications? Visual vision disturbances in terms of knowing which tablet to take. And then lastly, the support of having nurses that go out to the community, all of which helps with significant compliance and adherence. What we have noticed is that if you try to tell a patient, this is the medication, go take it, it's good for you, it's good for your heart, take it. Sometimes patients may not feel to take all of those medications because they may say, well, my friend was on that medication and he had an infection, end up in the hospital, and all this a new branded drug of what we call SGLT2 had a bad infection, urinary tract infection, and I want to take it. So really going through the discussions of why somebody has a particular barrier increase the compliance as high as more than 25 to even 50% in that population. So that's the first thing, identifying barriers and having the support to deal with it. And then two, where you can, as mentioned before, de-prescribe pills or switch pills into combination to decrease the pill burden. And those two strategies have significantly improved outcomes in my patients. So that answers the first question. The last one you had mentioned was regards to robotic surgery in cardiac disease. One of the big things with robotic surgeries we know is sort of like the minimally invasive type of procedures that are done, where sometimes the entire bypass surgery can be done robotically. Right now, in terms of intervention, robotic hasn't taken a significant hold in terms of intervention and putting stents. It is on the platform, and it melds with towards what your middle question was with regards to AI integration. The American Heart Association, as well as the ACC, last year, and SKY as well, AI was a huge component in some of these meetings where the discussion of integration towards how far it can assist with surgical outcomes as well and procedures. So I think in years, probably in the 5 to 10 years, AI is going to be a significant contributor towards not only procedure, but in terms of the overall patient care plan. Okay.
Thank you, Dr. Ravi Ramlal. Our next question to Dr. Jayantha Sharma. What legal safeguards should physicians be aware of while dealing with geriatric concerns and decision making?
Yeah, very excellent question. The question we have asked it very practical and definite. The question the geriatrician usually faces in their practical portions when they are inside the hospital. The legal safeguards, this is a multidimensional approach, because nowadays each and every aspect what we are, there are 3 or 4 aspects out there. One is the documentation. The legal safeguards for a physician or geriatrician, not the geriatrician, for all the physicians, the clinicians, nowadays the most important is the documentation. Each and everything, whenever you are dealing with critical patients or elderly patients, the most and important is the counseling. This is number 1. Second is the counseling, what you are doing, that should be either documented in the form of physical documentation or telephonic documentation or the on-camera documentation, whatever. That is the most important. And if anything happens, this documentation is there which can save you and your clinics, that is your colleagues. This is the number 1. Number 3 is the first one is the documentation, second is the counseling, and the third one is the decision making. And regarding the decision makings and these things, always you do a joint counseling with your colleagues, involve the medical board and medical ethics committee of your hospitals for any clinical decision and legal decisions whenever it should be in front of the patient's family and in the medical ethics committee. If the patient needs any do not resuscitate, end of life care decisions and everything have to be taken, that should be the joint decision in front of the medical board, in front of the hospital ethics committee. We should take that. And these are the safeguards for physicians when the patient should take the geriatric ultimate or end of life decisions.
I think it's an excellent point, Dr. Jayantha Sharma, that you have made. Most of the problems arise because of the gap in communication, and most of the problems, they erupt because of the lack of documentation. I think you have touched these very vital points, and nowadays in the era of legal battles coming so quickly, instigated by many people, it's good to have a proper communication, proper documentation, and a proper record of it. Excellent. So friends, I think it's time to end the session. We are really thankful to Lavanya for taking this initiative and asking us to do a seminar on geriatrics. I'm thankful to Gapio for this wonderful opportunity, to our listeners and to our speakers who have come prepared to answer all the queries. I'm thankful to Geriatric Society of Trinidad and Tobago. I'm thankful to my speakers, Dr. Taureef Mohammed, Dr. Ravi, Dr. Jayantha Sharma, and all those who have participated by asking questions. At the end of it, I would like to say that we would like to work jointly on the platform of education, on the platform of exchange of ideas, on the platform of sharing the experiences, and we would like to have more of such seminars. Thank you so much. Thank you once again. Namaskar. Good night.
Good night, sir. Good night, all of you. Good night, Lavanya, and good night, all of faculty members.
Thank you.